if you have a burning problem, just like interrupt, okay? All right,
And
let's go.
you could also mute yourself so there's no background noise.
I will do that, and I am very glad for all your tips.
Thank you.
You guys are great. Let me mute myself. Now, fluorescein angiography is a photographic technique that's been around since the 1960s. And we used to do it on film. Nowadays, we do it digitally. And what we do most of the time is to inject the intravenous fluorescein to get the fluorescein angiography. However, you need to know also to get a fluorescein angiography by ingesting fluorescein. And this we can do in small children for who we cannot give an intravenous injection. What we will see in those cases is the late frames of the angiogram, the diluted fluorescein. Now, fluorescein angiography is an extremely important tool that will allow us to study the retinal and the choroidal circulation. It will allow us to diagnose macular diseases, retinal diseases, inflammatory chorioretinal diseases, tumorals, and other conditions of the choroid and retina. And it's also a very effective guide for evaluating treatment success. We use fluorescein, which is an orange-brown crystalline hydrocarbon liquid. It has a low molecular weight and it diffuses very readily through capillaries. The dose that we use needs to be known. It's 15 milligrams per kilogram, and the fluorescein is bound to plasma proteins very readily, and it's eliminated very quickly by the kidney and the liver in 24 hours. Fluorescein angiography resides on the principle of luminescence. We inject fluorescein into the bloodstream. It goes throughout the body, including the retinal arteries and veins, and we hit the retina with a blue light at 465 nanometers. This light is going to excite the fluorescein molecules, meaning that the electrons in the fluorescein are going to rise to a higher level of energy by putting a blue filter on the light. So we will excite the fluorescein with a blue light, and then we will, once the molecules return to a normal state, they are going to emit energy, and that energy is emitted at a longer wavelength, a green wavelength, which is captured by a green filter. So a camera system will put both the blue filter and the green filter and will capture the fluorescence that is in the circulation electronically. Now, those filters must be perfectly matched. If they are not perfectly matched, the image will not be very clear, which is what we call pseudofluorescence, which is what we see here, in which this appears as a background illumination, and it can confuse the interpretation of the fluorescein angiogram. Now, we cannot interpret a fluorescein angiogram if it's done without a standard protocol, and the standard protocol involves first taking color fundus photographs of the retina. Then we do a red-free fundus photo. This means that we will put the green filter, and this will allow us to see the optic nerve in white, and the vessels will be dark. Thereafter, we will put the blue filter, and we will take another shot, which is what we call a control shot. This tests the filters. This makes sure that the filters are matched. Through a control shot, we should not be seeing anything. Everything should be dark, except if there are lesions in the fundus that are autofluorescent. That is the time where we can see them autofluorescing, meaning they are bright, shining without the injection of fluorescein. Once we have made sure that the control shot is good, we will inject the bolus IV 10% fluorescein at the dose which I told you, 15 milligram per kilogram, and give a saline flush. We will do the fluorescein angiogram in a standard protocol in which we do a transit phase of the study eye. We will start with the arterial choroidal and then the arterial filling. We will wait until the veins are completely filled, and thereafter, that is called the transit phase, and thereafter we will take late photos of both eyes, that is of the eye in question, but also of the fellow eye. And the information provided will allow us to get an idea about the flow characteristics of the choroid and the retina, an anatomic study that shows the fine details of the RPE and the retinal circulation, and the retinal pathology that is not visible by a standard exam, And the fluorescein angiography will also allow us to study functionally the integrity of the retinal vessels and the RPE, that is the inner and the outer retinal barrier. Let's look at the anatomic and physiologic foundations of fluorescein angiography. We all know that the retina has a double circulation. First of all, a retinal inner circulation that provides supply blood to the inner two-thirds of the retina by means of the central retinal artery and, let's take him back, by the central retinal vein, but also an outer circulation provided by the large choroidal vessels, giving rise to ciliary arteries and choriocapillaries, and where the blood is taken back through the vortex veins that we can see here. We need to know that the retinal blood vessels do not leak, and they form the inner retinal barrier. So the blood goes through the blood with fluorescein or without fluorescein goes through these vessels and does not go into the retinal tissues. And the retinal circulation is an N-type circulation, meaning that it bifurcates, the retinal arteries will bifurcate to smaller and smaller vessels until they reach the fovea centrally, giving the foveolar vascular zone, or reach to a place in the periphery where they just connect with the veins. The choroidal circulation supplies the outer third of the retina, that is, it supplies blood to the photoreceptors, the outer nuclear layer. It is formed of large and medium vessels, which are impermeable. They do not let the fluorescein go through them, but these vessels will divide into smaller vessels, into choriocapillaries, precapillary arterioles, and then choriocapillaries. And these choriocapillaries have a very distinctive lobular distribution, and what is important about them is that they leak. So fluorescein that enters the choriocapillaries will diffuse and will leak from the choriocapillaries into the tissues surrounding them. Now this choriocapillaries leakage is going to stain the background, is going to stain the choroidal stroma, is going to stain the Bruch's membrane and the sclera and the optic nerve, giving this background fluorescence. If you notice, the background fluorescence here is brighter than the fovea, which is very dark, and that is because the stroma of the choroid and the sclera and the Bruch's membrane have some fluorescein that has stained them. The RPE is the layer between the choriocapillaries and the photoreceptors, and it acts as a barrier. It's going to prevent the leakage that is coming from the choriocapillaries into the retina, keeping the retina intact and dry. But the RPE also acts as a curtain, as a screen, because it has melanin, which will dampen the transmission of the choroidal fluorescence. And therefore, you will see a choroidal fluorescence and a certain brightness. At the fovea is darker. And that is because the RPE in this area is more packed with pigment, and there's also the xanthophyll pigment in the retina that prevents the light from reaching the background, and that's why you have a brighter background elsewhere than in the fovea. Therefore, the choroidal visibility, the background visibility, is going to depend on the density and the distribution of the pigment in the RPE and the choroid. Notice here that if you have RPE atrophy, that is less melanin, you will have the brighter background because you don't have the melanin to stop the background from shining. However, if you have, right, as we can see here, choroidal atrophy and choriocapillaries atrophy, there will be no choriocapillaries to leak, and therefore the background will be darker in this area. Here's an area of geographic atrophy, and you can see the corresponding fluorescein. It is very dark because the choriocapillaries are missing and there's nothing to leak from. Here's again another example of an RPE atrophy and choriocapillaries atrophy in a patient with gyrate atrophy, in which you can see that the background fluorescence is very, very dark. Now the RPE is loosely attached to the neurosensory retina, and this is why when you have leakage between the RPE and the neurosensory retina, it can pool and it can diffuse, and the bleb of subretinal fluid can enlarge. However, the RPE is firmly attached to the choriocapillaries via the Bruch's membrane, and therefore when you have pigment epithelial detachments, such as here, the leakage will remain circumscribed. The fovea must remain very dark. It's about the size of the optic nerve in diameter, 1,500 microns. I apologize. And the fovea has no retinal capillaries, and as I said earlier, it has to appear dark because you have more pigmented RPE in the center of the macula. You have also the xanthophyll pigment that also prevents the transmission of light, and therefore the fovea must remain dark. The optic nerve head circulation is double, both from the posterior ciliary vascular system and the choriocapillaries at the top of the optic nerve, and there are anastomotic channels between both. The vitreous is clear, and therefore it is not fluorescent. If you have vitreous opacities, they're going to interfere with the entry of light and they will give you blockage of the retinal and the choroidal fluorescence, that is hypofluorescence. However, if you have inflammation or retinal neovascularization, the vessels will leak and the leakage will go into the vitreous, staining the vitreous, giving hyperfluorescence. Let's look now at the choroidal fluorescence. Let's follow a molecule of fluorescein as it goes from the arm towards the eye. Thinking now and concentrating only on what happens at the choroid itself. Now the fluorescein enters the choroidal space through the large choroidal vessels at approximately 13 seconds, and approximately 1 second before the fluorescein appears into the central retinal artery. So it enters through the large choroidal vessels, right there, and before it enters into, and it immediately goes into smaller choroidal vessels, making its way towards the choriocapillaris lobules, as you can see here. The large choroidal vessels, we said, are not fenestrated, so the fluorescein is going to pass through them, and since the background is dark and doesn't have any fluorescein, the early shots will show you that there are lines, hyperfluorescent lines, discrete lines that correspond to these large choroidal vessels that are silhouetting against the dark background. As the fluorescein enters the choriocapillaries, those choriocapillaries are going to start to leak the fluorescein into the lobules. And since this is an independent lobular distribution, the lobules are going to fill independently. We have giving, therefore, what we call patchy choroidal filling. The independent lobules, as you can see here, this lobule has filled, while here this lobule has not filled, and it is still hypofluorescent because of the unequal distribution of the lobules. And this patchy choroidal filling is normal, so when you see it in the early phases of the angiogram, you should not think immediately that there is no choroidal perfusion. You should wait a few seconds and see if the choroidal filling becomes homogeneous or not. The choriocapillaris lobules are going to fill slowly and independently and continue to fill an extra, and the fluorescein is going to go out of the choriocapillaris, as we said, because they leak and start staining the stroma. As you can see here, the background fluorescence is already increased compared to the previous one, which was here. That is because of the leakage of the choriocapillaris. And the leakage continues until we reach a peak of fluorescence that is very bright at approximately 20 to 25 seconds, which is what we call the choroidal flush. Thereafter, the choroid is going to empty itself from the blood that is heavily stained with fluorescein and is going to receive blood from the circulation that is no longer stained as much with fluorescein. Because every time that you have to think of it this way, the fluorescein goes through the arm, goes through the blood, goes through the arm and to the heart, and the heart sends it to the eye. So the first bolus of blood has a lot of fluorescein in it, but as it leaves the eye and it goes back to the lungs and to the heart and goes to the kidney where it's filtered, the second circulation is going to have less concentration of fluorescein in the blood. Therefore, from now on, every blood that goes in the eye is going to be less concentrated than the first initial bolus of fluorescein, and you will have a continuous exchange between what is very highly concentrated fluorescein in the eye and blood that has less fluorescein, and therefore the fluorescence is going to decrease steadily in the eye after that peak. So to recapitulate, after we went through the choroidal flush, where there is bright homogeneous filling of the choroidal background, you will have a phase that we call the early recirculation, in which the intravascular fluorescein decreases and the fundus background becomes gradually darker. This continues, the darkness, the progressive darkness, further decrease and clearance of the fluorescein. And at this point, the large choroidal vessels are no longer well stained with fluorescein. However, the stroma is stained with fluorescein. Therefore, these large choroidal vessels that are bringing in blood that is not heavily stained with fluorescence, they're going to silhouette as dark lines against the stroma that is still stained with fluorescein, as we can see here. And this is how you know that you are in a late phase, because the background fluorescence is not as bright and you have large dark lines against a background that is slightly brighter. In the late recirculation, the large choroidal vessels appear pretty much dark, and even the background fluorescence is dark. So here to recapitulate, you have the patchy choroidal filling. Then this patchy choroidal filling increases steadily until you come to what we call the choroidal flush, a homogeneous fluorescence, and then the fluorescein in the background is going to decrease steadily. Now let's look at what happens simultaneously in the retinal circulation. And the retinal circulation is divided in several phases that we will talk about immediately. First is the arm retina transit phase, in which there is no fluorescence in the retina yet. This is the time between when the fluorescein enters the blood stream and where it first appears into the eye. So at this point, this is about 13 seconds and there is no fluorescence in the retinal circulation. If you have a ciliary-retinal artery, you will see fluorescence in the ciliary-retinal artery at the same time as the choroidal circulation. Notice that in this particular frame, you have patchy choroidal filling, because the choroid, as we said, fills 1 second earlier before the retinal artery. And there is no fluorescence at all in the retinal arteries. But if you have a ciliary-retinal artery, it's going to fill at the same time as the choroid before the retinal artery, and the ciliary-retinal artery is going to be brighter than the rest of the retinal arteries. The arterial phase is a pretty rapid phase. The arterial phase shows homogeneous arterial filling throughout the arteries that should be complete within 1 to 2 seconds. Arterial phase has to be rapid and homogeneous. This is the characteristics. Then we have what we call a laminar venous phase, in which the retinal capillaries are bringing back blood towards the veins of the retina. And what you see is a very peculiar pattern of this laminar pattern. This distinguishes the veins. These are the arteries. They are completely filled. They are crossed by vessels that have this laminar pattern. And the laminar pattern exists because the blood that is already stained with fluorescein in the retinal capillaries is going back towards the retina, towards the circulation, the main circulation here. But here the veins are still dark, and that is because the arteries that have filled, are still not completely, have not yet reached the capillaries here, and therefore the blood that's coming from the capillaries in the periphery is still not stained with fluorescein, and therefore this blood is moving in the center very rapidly, in the center of the venous column, while the areas in the retina, the proximal areas closer to the optic nerve that already have their capillaries filled and bringing back blood in the veins, those are going to fill in the veins at the periphery, giving this laminar pattern. And this is a very characteristic flow. So laminar venous phase is an early phase of the angiogram. And the laminar venous phase continues on for about 12 to 15 seconds. Thereafter, we have what we call the venous phase, and this is a phase where the veins are equally bright as the arteries. Both of them are very, very bright. This is the venous phase, which stays about 12 seconds as well. Then we get into what we call the early recirculation phase. From this time on, the veins are going to bring back blood that is highly stained with fluorescein, while the blood that is coming again into the arteries from the main circulation is less stained with fluorescein, explaining why the veins are always going to be brighter than the arteries. And here's a tip that you should know. If you are in a phase of an angiogram in which you see vessels that are crossing each other, you need to remember that there are in the retina, veins do not cross veins and arteries do not cross arteries. It is always a cross between veins and arteries. So if you have two vessels that are crossing each other and you have one vessel that is completely filled and the other vessel that is completely filled, the brighter vessel is always the vein. And that's how you distinguish veins from arteries. The late recirculation continues with the background becoming slowly, progressively less fluorescent, and also the fluorescence in both the veins and the arteries is less intense. But remember, again, the veins are always brighter than the arteries, and that is how you distinguish them. So, to recapitulate what happens to the retinal vessels, to the retinal fluorescence, it starts 1 second after the choroid. The arterial phase is very rapid. It should finish within 1 to 2 seconds, followed by a laminar venous phase until the veins are fully filled and very bright and equally bright as the arteries. Then you start in the recirculation phase, where the intravascular fluorescence gradually decreases, but the veins remain brighter than arteries, and at no point normally is there any leakage. So, now that we've seen the concepts, let's see how do we read a fluorescein angiogram, and there are certain rules. You have to be systematic when you read a fluorescein angiogram. You ask yourself, is there abnormal fluorescence? Now we have seen what a normal fluorescence looks like. So anything that deviates from this pattern is abnormal fluorescence. And if it deviates, it will be either more fluorescent or less fluorescent. So you ask yourself, is there abnormal fluorescence? If yes, is it hyper or is it hypofluorescence? In what pattern is the abnormal fluorescence? Meaning, does it increase with time? Does it decrease with time? Does it stay steady? And then at what level is the abnormal fluorescence? Does it seem like it's in front of the retinal arteries? Is it inside the retina, or is it behind the retinal arteries in the choroid? And in what distribution? Is the abnormal fluorescence localized to a certain area in the fundus, or is it all over? Is it sectoral? Does it respect the horizontal raphe, for instance, and so on? This gives you a clue on how to interpret fluorescein angiogram. Let's look at the patterns of hyperfluorescence. There are 5 hyperfluorescences: pre-injection fluorescence, window effect, leakage, pooling, and staining. The first pattern is a pre-injection hyperfluorescence, which comes in when we see it before any injection of dye has happened. Either pseudofluorescence, when we have mismatched filters, we're seeing a bright background which shouldn't be there, and that's because of technical fault. Or there are actually structures inside the retina, such as optic nerve head drusen or best vitelliform lesions, which are bright by themselves. They cause autofluorescence, and we can see them as soon as we take the control shot. We don't need fluorescein, we can see this immediately with a control shot. But what happens once we inject the fluorescein? There are therefore 4 types of hyperfluorescences. The first is a window effect. The window effect means that the RPE that normally blocks visibility of the choroidal background is lacking in melanin or atrophied, and therefore it lets us see the background fluorescence much readily, in a much brighter way. And the fluorescence is going to parallel the choroidal fluorescence, meaning that in the beginning the background fluorescence is dim, it increases, and then it decreases, but the area in which the RPE is atrophic, in that area the fluorescence is going to appear brighter than the rest. It's going to increase simultaneously with the rest of the background fluorescence, but when the background fluorescence dampens, it also dampens, it decreases, but remains always brighter than the rest. The margins are always distinct, and the size doesn't change. The level is always subretinal. A window effect always means an atrophy of the RPE or a depletion of the pigment of the RPE. The other pattern of hyperfluorescence is leakage. Leakage means that fluorescein is going out of the normal barriers. Either you have incompetent blood vessels in the retina, which, as we said, they should not leak. The vessels of the retina do not leak. So if the vessels of the retina leak, you have incompetent inner barrier, or you have an incompetent outer barrier, an incompetent RPE. And the leakage pattern is early continuous increase, a steady increase in the fluorescence, a steady increase either in intensity or in size or in both. The margins of the leakage is always fuzzy, and the level of the leakage can be inside the vitreous, inside the retina, or under the retina. For instance, if you have diabetic retinopathy with pre-retinal neovascularization at the level of the optic disc, they are going to appear in front of the retina, and the leakage is going to happen inside the vitreous, as you can see, because the vessels leak inside the vitreous, causing a fuzzy, intense increased hyperfluorescence with fuzzy margins that do not let you see the background fluorescence. This is leakage inside the vitreous. Again, vessels in the periphery, like in ROP, where you have neovessels in the periphery, they can also leak into the vitreous, masking the background fluorescence. Leakage can happen inside the retina, for instance, in diabetic retinopathy, when you have tiny microaneurysms, such as here. These microaneurysms are going to steadily leak. As you notice, that each tiny hyperfluorescent dot that you can see, which you already recognize is abnormal, because you shouldn't be having hyperfluorescent dots here, but these hyperfluorescent dots, within the late frames of the angiograms, you will start to notice that they become very fuzzy around them because of the leakage of the fluid staining the retinal tissues. How do I know that this is an early frame and this is a late frame? Well, from the clues that I told you about. The background is brighter, the vessels are brighter, while here the background is dimmer and the vessels are dimmer. Leakage can happen also from widespread intraretinal abnormalities, again in vascular diseases such as diabetic retinopathy, where you have a lot of microvascular abnormalities, and all of them leak, and this area becomes very fuzzy and super hyperfluorescent towards the end. Leakage can happen inside the retina from retinal telangiectasia, such as this case of juxtafoveal telangiectasia, in which you have telangiectatic vessels, and throughout the fundus it starts to leak and become fuzzy. Or in Coats disease, again, where you have retinal telangiectasias, and which also become very hyperfluorescent towards the end and fuzzy. So the fuzziness and the increase in size is very characteristic of leakage. Leakage can happen in retinal arterial macroaneurysms inside the retina, and leakage can happen under the retina, such as in choroidal neovascular membranes. Here, for instance, you have a choroidal neovascular membrane with drusen in an age-related macular degeneration. Early on, you can see an area of abnormal hyperfluorescence, and this abnormal hyperfluorescence increases in intensity and in size, and it is surrounded by fuzziness, signaling that it is leaking. Leakage can happen also from tumoral vessels, such as capillary hemangiomas, which we can, for instance, see here. You have vessels inside the tumors, and they also leak, causing diffuse staining of the lesion in retinoblastomas, hemangiomas, and a lot of choroidal tumors. Now, alternatively to vessels, you can have a problem of incompetent barrier of the RPE, such as in inflammation or in conditions such as central serous chorioretinopathy. Here, for instance, you have an area of hyperfluorescence that is very small, and this area increases in size, and it becomes fuzzy, and it therefore pools. The fluorescein is pooled here inside this oval area. If you notice, this area is more hyperfluorescent than the rest. This is what we call pooling because of leakage from this hyperfluorescent spot, which is the incompetent place at the RPE. Now, we call leakage into a space pooling, as we just saw. Now, pooling can be under the pigment epithelium, and this is for instance, a pigment epithelial detachment. What you will see is an early hyperfluorescence that increases in intensity, but not in size, steady increase in intensity, and this is because the fluid that comes from the choriocapillaries under the RPE will stay circumscribed because of the strong adhesions between the RPE and the choriocapillaries at the edge of the PED through the Brooks membrane. Therefore, the fluid cannot escape that area, and the intense hyperfluorescence will remain circumscribed and remain sequestered in this pigment epithelial detachment. However, if the incompetent barrier and the fluid goes through the RPE under the retina, then we will see what we saw earlier here, is that you have an early hyperfluorescent dot that increases in size and intensity and gives a pooling of a blob of fluid that increases in size throughout the angiogram. Now, pooling can also happen inside the retina in the outer plexiform layer, such as we see in a cystoid macular edema. Here you have an incompetent vessels, and increased visibility of the perifoveal capillaries, and they are leaking. And you know that they're leaking because everything becomes fuzzy in the late frame, and the pooling occurs into the little cavities of the outer plexiform layer. We know that this is an early phase of the angiogram because the vessels and the background are bright, and here you are in the laminar venous fold, so you are in the transit phase, while here we know, even without a timer, that this is a very late phase because everything is very dark and the fluorescence in the vessels is quite dim. Now, if leakage happens into a tissue, staining the tissue, we call that staining. Staining can occur in scars, in drusen, and in staining of the sclera. The pattern is steady increase in intensity. Usually the size is stable and the margins are distinct. For instance, if you have traction on the retina, you can have staining. If you have inflammation of the vessels, the area of the retina next to the vessels is going to be hyperfluorescent, something that we call staining. And if you have vascular occlusions, the ischemia causes staining of the vascular wall. Here you have staining of the sclera in an area of chorioretinal atrophy. Let's look at this very slowly together because this may be difficult for you to immediately understand. Here's an area of geographic atrophy in a patient who has cone rod dystrophy. There is an atrophy of the choriocapillaries and the retinal pigment epithelium. In the early phases of the angiogram, what we're seeing is a dark area, and this dark area has multiple white strands here, which correspond to the medium-sized choroidal vessels, which do not leak. There is no choriocapillaries, therefore the background fluorescence is there are no choriocapillaries to leak and give you background fluorescence. This is why we see those the darker vessels so clearly, because there is no background screen. Here, the choriocapillaries is leaking, staining the background, and there is RPE that dampens the choroidal fluorescence. While here, there is no RPE, but there is also no choriocapillaries, and therefore what we're seeing is just the big choroidal vessels that are bringing the fluorescein, and they do not leak. Now, as time goes by, the choriocapillaries that are around the edges of the atrophy, in here, these still viable choriocapillaries are going to leak, and they're going to leak and stain the Bruch's membrane and stain the sclera. And therefore, you start to have scleral staining, and that's why you have hyperfluorescence. And this hyperfluorescence is going to slowly migrate. Slowly, the tissues that are being stained are going to slowly become more hyperfluorescent. And if the area is big, if the area of choriocapillaries atrophy is small, then it is very easy for this whole entire area to become hyperfluorescent. While here, if the area is large, then it will take time for the sclera to stain and to reach the center. This is why scars tend to have usually a hypofluorescent center with a hyperfluorescent rim because of the staining of the viable choriocapillaries at the edge. In this area here, you have hyperfluorescence compared to the rest of the background, and the hyperfluorescence here is due to the fact that there is choriocapillaries that is leaking, but there is an atrophy of the RPE and less pigment to dampen this choriocapillaries leakage. Therefore, the background here appears brighter than the background here. This is a window effect, and this is staining here. Now, drusen can stain. These are little tiny pinpoint spots that you see throughout the fundus that do not leak at the end of the angiogram, so they are not microaneurysms, because we saw microaneurysms that they are incompetent vessels that leak. Drusen do not leak, and again, we know that this is a late frame and this is an early frame because here the veins are pretty bright and here the veins are not as bright. Staining can happen in inflammations. Usually inflammatory tissues tend to block fluorescein in the beginning, but then at the end, the inflammation, the vessels inside the inflammatory tissue leak and they stain the background. Now, we've seen hyperfluorescences. Let's look at hypofluorescences. Now, there are two types of hypofluorescences, either blockage or a filling defect. Blockage means that the filling happens normally, but there is something in your view that doesn't allow you to see it. Filling defect hyperperfusion means that the fluorescein is not entering either the retinal or the choroidal circulation. Now let's look at blockage. Blockage can be from anything. It can be from a media opacity, such as a cataract or a foreign body or a corneal opacity. Blockage can be pre-retinal, can be intraretinal or subretinal. And the blocking material can be pigment, which includes melanin and hemoglobin. Hemoglobin is a pigment. It can be exudate, edema, if it's very thick, lipofuscin, drusen, or as I said, a foreign body. And the pattern of blockage is that it's always stable in intensity and in size. Here's a blockage by melanin in a patient who has a melanocytoma. This is an early phase of the angiogram at the laminar venous phase, which is an early phase in which we can see patchy choroidal filling. So a very early phase of the angiogram. And this is the late phase of the angiogram in which the big choroidal vessels are darkly silhouetting against the staining background. And you can see that this lesion here, which is very dark, hypofluorescent, has not changed in size. This is blockage from a choroidal nevus because the melanin blocks the visibility of the choroid. Blockage in congenital hypertrophy of the retinal pigment epithelium, in which you have a lot of melanin that blocks this area. Blockage because of pre-retinal blood in a macroaneurysm. Here you have pre-retinal blood, you have an area of hypofluorescence that starts early, that masks the retinal circulation, and that continues throughout the late phases of the angiogram. Again, you can know that this is a very early transit phase with a laminar venous flow. Here you are in the beginning of the recirculation phase, with the veins being a little bit brighter than the arteries, and here you are in the late recirculation phase, with the veins being brighter than the arteries, but much dimmer than earlier on, and with a much dimmer background. And the area that is blocking the visibility of the background choroidal fluorescence and the retina is intact and the same, and has not changed in intensity or in size. Blockage can be due to intraretinal blood, such as we see here when we have retinal vascular disease. So the blood blockage can happen under the retina, such as this case with the retinal macroaneurysm, in which there was blockage under the retina. You can see the retinal vessel silhouetting very nicely, knowing that the blood therefore is masking the choroidal circulation. Some of it is, however, masking the retinal circulation, so this is a combined pre-retinal and subretinal blockage. This is again another macroaneurysm that has bled intensely. The blockage is in front of the retina. In this area, it is under the retina in this area, because you can see the retinal vessels, and here it is in front of the retina as well. And there is some intraretinal blockage, as you can see here. Best disease with lipofuscin and lots of fluorophores in the subretinal blood can also give you blockage. If you do an autofluorescence, you will see high hyperfluorescence, but as soon as you inject dye in the eye, the background becomes so bright. This hyperfluorescence, hyperautofluorescence is relatively speaking not as bright as the rest of the background, and therefore it blocks. Here's another example of Best disease in which the bleb of subretinal material that is filled with fluorophores is blocking the visibility of the retina. In this case, blockage is happening throughout the RPE in the case of Stargardt disease, giving what we call a choroidal silence. Here it is. The choroidal silence is throughout the fundus, and in this area you have RPE atrophy, and this is why you have a window effect. The second type of hypopresence is hypoperfusion, which occurs when you have a problem in the perfusion in the retinal arterial circulation, either the main artery, the precapillaries, or any peripheral capillary non-perfusion, but also in the choroidal capillaries if you have, for instance, malignant hypertension. These are examples of retinal hypoperfusion where you can see hypofluorescence because there is no capillary perfusion in the retina, either here or here. Let me put this arrow here or here. These are all areas of capillary non-perfusion. Notice that they are darker than the rest of the background. This is a choroidal hypoperfusion. We've talked about this earlier. in a case of gyrate atrophy where there's tremendous loss of choriocapillaries, and you can see that there's no capillaries. All what you see are the main the main bright choroidal vessels at the early phases. Now, when we read fluorescein angiogram, we have to have a systematic approach. We have to look at the background. Okay, so you just heard the basics of interpreting the fluorescein angiography, and this is, I guess it's pretty heavy for you, all that information at the same time. So we'll take a few moments to entertain questions before we go and see some cases for you to, to understand this a little bit better. So what questions do you have so far? Can you hear me?
Yes. Can you hear me, Doctor?
Yes, it's a little far, but yeah, go ahead.
Yeah, there is, when you said the type of blockage, you said there is blocking material.
Yes.
And there is edema, and there is retinal infarction.
Yes.
How is that different from hypoperfusion?
Okay, good question. Hypoperfusion, do you guys hear me? Do you hear, because I hear an echo, do you hear me?
Yeah, we can hear you.
Okay, thank you. Basically, hypoperfusion is when you have less blood going into an area, okay, where maybe the artery is blocked and therefore you have a hypoperfusion, all right? So in this case, of course, you're going to have no fluorescein going into that area and it's going to be pretty dark. However, if you have, for instance, in addition to this dark area, because you don't have blood going into it, you have the nerve fiber layer that gets swollen, infarction, okay? That same swelling is going to block the perfusion of the choroid, of the background. I want you to think of a fluorescein angiogram in layers. I want you to think of the choroidal layer doing its thing and the retina doing its thing. So if you have a hypoperfusion of the retina, for instance, like a branch retinal artery occlusion, or even a branch or a central retinal artery occlusion, so you get no retinal perfusion. You get no retinal filling, right? You don't get capillary filling of the retina, right? You're with me on that, correct?
Yes, I'm with you.
Okay, so you will get hypoperfusion, you get hypofluorescence in the retina because there is no blood going into the retinal circulation. However, the choroidal circulation is okay. So you should be seeing the patchy choroidal filling, and you should be seeing the choroidal flush, and you should be seeing the staining of the Bruch's membrane and the sclera, correct?
Yes.
Yes, you should be seeing that. Even if the retina does not fill, the choroidal circulation is good. Now, but what you have in the retina when you get a hypoperfusion, you get an infarction. You get a stasis of the axoplasmic flow. You get basically a swelling of the nerve fiber layer because it is so ischemic that the axoplasmic flow in the axons just stops, and you get a swelling like a major large cotton wool spot. And that cotton wool spot is going to block the visibility of the choroidal fluorescence in that area of the background. Do you get it?
Yes, excellent. Thank you so much.
Okay, so you have degrees of hypofluorescence. Some, if you have a lot of blood, like I showed you that pre-retinal blood earlier with the macroaneurysm, that is a very, very big blockage. Everything was blocked. Everything was black, basically. You couldn't see anything. But if you have a relative, blood that is not so thick, if you have material that is not so thick, if you have like an infarction when it is not so thick, therefore you can still see through it, and the blockage, yes, it will be blocked compared to the surrounding area, but it will not be maybe as black, as dark. All right, do you guys understand the difference between a window effect and leakage, pooling, and staining?
Excuse me, doctor, I want to ask about it. In case of choroidal atrophy, I
Yes.
understand window face, but the leak from where it's come?
Okay, again, imagine the choroid has a lobular distribution, which we talked about yesterday, and I alluded to this time. Do you guys remember that? Do you guys remember the choroidal circulation?
Yes, Doctor.
Okay, so basically you have lobules of choriocapillaries that each lobule belongs to a specific pre-capillary arteriole that itself belongs to a larger, choroidal ciliary arteriole. Now, when you have basically one choroidal arteriole that does not bring in blood, the lobule itself, the choriocapillaris itself, is not going to be perfused, okay? So this may cause a little delay in the choroidal filling. But if you have a pathology, for instance, you have age-related macular degeneration, or you have a pathology in which the RPE and the choriocapillaries are very attenuated, such as in chorioderemia, for instance, or a gyrate atrophy, or even a scar, even a laser scar. You burnt the choroid with the laser, and now you have atrophy of the choriocapillaries. If you have atrophy of the choriocapillaries, where is that lobule is gone? You're not going to get any blood in that lobule, okay, at all. So that area where the choriocapillaris is atrophic, is gone, is dead, is finished, is no longer there. That's going to remain dark. But the surrounding choriocapillaries around that area are still viable and are still, capable of leaking, because leaking is what choriocapillaries do. That's what they do. Choriocapillaries leak. So therefore, they're going to leak, and they're going to leak into behind them. They're going to leak into the stroma. They're going to leak into the sclera behind them, and they're going to leak into the Bruch's membrane that covers them. Okay, and because you have the stroma of the choroid that is now going to be staining with all that, fluorescein that comes from the choriocapillaries that leaking. What is staining? Staining is taltikh, يتلطخ. The stroma تتلطخ, السclera تتلطخ بالفluorescein. As if you throw a little bit of ink, you throw the ink on your tissue, on your t-shirt, والt-shirt حقك يتلطخ. So you get a stain, okay? And that staining is going to make the area of the absent choriocapillaries appear bright in the late phases, not in the early phases. So in the early phases, it's going to be very dark. And in the late phases, the edges are going to become much brighter, okay? So you see this in every scar, in every burn, in every choriocapillaries loss, okay? A window effect is, on the other hand, different. A window effect, you have intact choriocapillaries. What you don't have is an intact RPE, or you have an intact RPE, but it lacks pigment. It doesn't have pigment, okay? The RPE is itself atrophic. The RPE is like a curtain. It covers the choriocapillaris leakage. It dampens, it decreases the brightness of the choriocapillaris leakage. So it decreases it all over the fundus. If you have an area in the choriocapillaris, if you have an area in the RPE that has less pigment, okay, it's like you have a curtain with a hole in it, okay? So basically you're going to get the brightness of the choroidal flush through that hole, and you're going to see it. So a window effect is an area of RPE defect, okay, that just lets you to see what's happening in the choroid in a much brighter way. And then as the fluorescein leaves the eye, because the intense fluorescence of the eye is leaving the eye while the eye is receiving now blood that is less stained with fluorescence, so the fluorescein is going to, decrease steadily. The intensity of the brightness in the choroid and in the retina is going to decrease steadily. Everything decreases. Okay, the choroid decreases homogeneously everywhere, but in that area where the RPE is missing, you're going to still see it brighter than the rest because you still have that hole. Do you understand it?
Yes.
There's no shame in not understanding. I want to make sure that you guys understand it. Basically, all what a window effect is an area of RPE that where the RPE is missing, or where the melanin and the RPE is missing. So the curtain is missing. So basically all what it does, it shows you what's happening in the choroid in a much brighter way than the surrounding area. And the choroidal circulation, basically what does it do? It increases until it becomes to a peak, and then it decreases steadily. Yes? This is how you recognize an early from a late angiogram. In the early angiogram, the choroidal filling increases in a patchy way because you have independent lobules. Okay, in the beginning it's very dark, and then you're going to see some patches that kind of pick up the fluorescein, and then with those patches eventually are going to become homogeneously, filling, and that until everything is really, really bright. And once everything is really, really bright, then it starts to decrease slowly over the 5-10 minutes that follows. Okay, so if you have a hole in the RPE that is in front of the choroid, it's between you and the choroid. You have, when you look at an eye from the outside, you're going in, you're going to hit the retina first, then you're going to hit the RPE, then you're going to hit the choroid. The choroid is further away from the camera than the retina. So you have a hole in the middle. You have an RPE that, that is, atrophic and doesn't have melanin. So you're going to see what's happening in the choroid in a much brighter way because you don't have that curtain that covers it. But it still goes up through the window effect. The fluorescence increases. And when the choroidal flush is at its peak, the area in which there is a window defect also increases. And then as everything goes down, the intensity of the fluorescence goes down, everything decreases. Even the area of that where the RPE is atrophic will decrease, but it will always, comparatively to the area surrounding it, it will always appear hyperfluorescent because it's just a hole. Do you guys get it?
Yes, Doctor, but what about the staining? What will happen over the phases?
The staining, what staining is as I said in Arabic, it's taltiq. So you have staining every time that you have a barrier that is broken. So if you have blood vessels that leak in the retina, okay, as an example, blood vessels that leak in the retina, such as inflamed blood vessels in the retina, okay? Those blood vessels, the leakage from the walls of the blood vessels is going to go inside the tissue of the retina, and you're going to see increased fluorescence of the retinal tissues next to the vessels or on the walls of the vessels with time. So staining doesn't happen immediately. Leakage doesn't happen immediately. Pooling doesn't happen immediately. These pooling and leakage are consequences of leakage. Okay? All right? So leakage, when you get leakage into, for instance, vessels that are in front of the retina, such as neovessels, you're going to get, where are they going to, fuzz and release their blood and the fluorescein and the liquid? They're going to release it into the vitreous, and you get leakage and you get this fuzziness. When you have a vessel under the retina that starts to also leak, like a choroidal neovascular membrane, it's going to leak under the retina and it's going to become fuzzy. All right. Now, if you have a bleb in under the retina or a bleb under the RPE, the fluid that is being leaked is going to go into that bleb, into that pocket, okay? And we call that pooling. So it happens over time. And if you don't have any bleb, if you don't have fluid, the leakage that's going to go from the area, from the vessel that is leaking, okay, or from the RPE, defect in the tight junctions, okay, then in that case, the fluid that is going to come up is going to go into the tissues, and that's when you get staining, okay? So for instance, exactly what I explained before, staining, like for instance, you have a scar, all right, you have fibrous tissue, all right, fibrous tissue in the choroid, or at the level of the RPE. Remember when I told you that the RPE has fibroblastic capacities. It can make a scar. So what happens is the choriocapillaries in the beginning, they receive blood and they leak, because that's what choriocapillaries do. They leak everywhere. But as they leak, since there is a tissue there that is capable of absorbing the leakage, which is the fibrosis, so it's going to start to accumulate the fibrosis. It's going to start to accumulate the fluorescein that comes from the leakage. And every time that there is a heart pump and more blood comes in and more fluorescein comes in, even if it's diluted, but you get more fluorescein, every time that there's more leakage, that tissue is going to accumulate more and more fluorescence. And so it's going to become bright and, brighter than the rest, because the choroid is supposed to dampen. Once the choroid has filled, and, initially at the 25 to 30 seconds with that choroidal peak, with the choroidal flush, the fluorescein is supposed to decrease in the eye. Decrease, not increase. But if you have a tissue that is capable of absorbing all the fluorescent material that is coming out of the leaky choriocapillaries, is going to accumulate. So it's not going to decrease, it's going to increase. Do you guys get it or no? Hello?
Yes, thank you, Doctor.
Yes, Doctor, here.
Is anything not clear? Because right now we're going to go and start looking at cases, which will help you understand a little bit more. But I want to make sure that you guys understand the passage of fluorescein into an eye, and what happens to the fluorescein. Do you understand it, or is it really shaky? It's important that you guys understand this.
Yes,
thank you, Doctor. Yes.
Okay, can we start?
Doctor, can I ask a quick question,
Of
please?
Of course, yes, of course.
Thank you so much. It's more related to the previous lecture, but since you mentioned it in this lecture regarding the cilioretinal artery.
Yes.
You said in previous lecture it's about 10% in people.
Yes.
And you said that previous lecture it's more permeable to fluids more than the retinal artery itself.
I didn't say that. I said that the choriocapillaries leak. And I said that the large and medium vessels of the choroid don't leak, right? So when you have a cilioretinal artery, you don't have a leaking artery.
Oh, yeah. Of course,
okay,
yeah.
so you have an artery that comes out from the choroidal circulation. The fluorescein reaches the choroidal circulation, the ciliary circulation, before it reaches the cilioretinal artery. Okay, so therefore the choroidal flush and all that choroidal filling is going to start 1 second before the central retinal artery. And if you have a cilioretinal artery that is lost its way, instead of going into the choroid, it went into the optic nerve by mistake, the one of those short posterior ciliary arteries. Instead of going into the choroid, right, it ended up going through the edge of the optic nerve into the retina. You're going to see it filling at the same time as the choroid, before the retinal arteries. But it does not leak, sir. Okay, it is an artery. It's a major artery, not choriocapillaries.
Oh yeah, thank you.
Okay.
Yes, I understand.
Anything else? Are you guys all there? Are you asleep? Are you all asleep? Does everybody know? Everybody's there? I think this is Rakan.
Yes, Doctora.
Yes.
Can we have this video after the lecture?
I have some difficulties giving videos out, but you have the handout that explains everything, and every Monday morning at 7:30 we have a Fluorescein conference. And if you attend for a few months, every Monday morning, just ask the residency to give you they're the ones that provide the link to the Zoom. Every Monday morning, 7:30 to 8:30, we have a Fluorescein conference. You'll learn much more by looking at cases, okay? So the principles, you have them in the handout, and also some tricks and tips. But, interpreting this, you get better at it by doing more and more, okay? All right, so let's go on. I hope this works now. We have to look at the optic nerve, the retinal blood vessels. Just a moment here. For instance. Okay, so I'll mute myself and take off the video. And hold on. Malignant hypertension. These are examples of retinal hypoperfusion, where you can see hypofluorescence because there is no capillary perfusion in the retina, either here or here. Let me put this arrow here or here. These are all areas of capillary non-perfusion. Notice that they are darker than the rest of the background. This is a choroidal hypoperfusion. We've talked about this earlier in a case of gyrate atrophy, where there's tremendous loss of choriocapillaries, and you can see that there's no capillaries. All what you see are the main the main bright choroidal vessels at the early phases. Now, when we read fluorescein angiogram, we have to have a systematic approach. We have to look at the background, we have to look at the optic nerve, the retinal blood vessels, and look for any unusual areas of hyper and hypofluorescence. We also do a chronological analysis, looking at how fast things go through the circulation. And then, as I said earlier, we try to localize the abnormalities according to the layer. Is the abnormality deep, or is it in the retina, or is it in front of the retina? And how does it, is it localized to a sector, or is it diffuse, or is it just macular, or is it peripheral, or is it, altitudinal, and so on. Let's look at a few cases now. Do you have any questions? Are there any questions? Can you still hear me? Are you there? Can you hear me? Okay, because there seem to be some people who cannot hear me. So in the sake of gaining time, perfect. And for the sake of gaining time, I'm going to go ahead and discuss a few cases with you. Here's a patient who here's a fluorescein angiogram of the right eye. As we look at it, we notice that the optic nerve is within normal limits, that the retinal vasculature seems to be intact. We are in the laminar venous phase, so we are in a relatively early venous phase, and we see the background. It is relatively homogeneous, but what attracts the attention is this pinpoint hyperfluorescence close to the fovea. This pinpoint hyperfluorescence seems to increase in size and intensity, therefore we can easily say that it's leaking. What phase are we in? We are in a relatively late recirculation phase. How do we know this? It's because the background is faded, because we can now see the large choroidal vessels silhouetting as dark lines throughout the fundus, and because the vessels themselves do not have much fluorescein in them. They are not brightly filled. This is the vein and this is the artery. We know that because the vein is always more fluorescent than the artery. So what attracts the attention is this spot that is now fuzzy and has increased in size compared to the previous one. What also attracts the attention is that here we can see the choroidal pattern very, very clearly, but here it doesn't seem to be as clear. It looks as if it's sponged. Much later, in a very late recirculation phase, we can see that the spot that we were talking about, this spot has now increased a lot in size and in intensity, and it's fuzzy. So we can definitely say this is leakage. Again, it is surrounded with an area that is very blurry, in which the fluorescence in this area, I'm sorry, I have to use this arrow, the fluorescence in this area here this area seems to be brighter than here, signaling that there is accumulation of fluorescein in this area. This is what we call pooling. What can this be? This is a typical case of central serous chorioretinopathy with a leaking spot that is, we call an ink blot and a neurosensory retinal detachment. Here is another case in which the early phases of the angiogram, well, not too early actually, because we are in a kind of a early recirculation phase in which the veins are brighter than the arteries, but in which the vessels are still relatively bright. We're seeing a hyperfluorescent dot right here and another hyperfluorescent patch right there. As we go, the hyperfluorescent spot is becoming increasingly bigger in size and it is fuzzy, therefore leakage. However, this spot, this patch, seems to have the same size and it has not changed. And if we go further on, now we know that we are in the late phase of the angiogram because the background is much darker than here and the vessels are not as bright. The small dot that was here is now leaking in a smokestack appearance, and this area here is still brighter than the rest. However, this area, same size, but it is less fluorescent. This is a window effect due to RPE atrophy. This is a hotspot due to an incompetent RPE pump that may give a pool of subretinal fluid. So this is a central serous chorioretinopathy with a neurosensory retinal detachment and some RPE changes at this year. Here's another case in which what attracts the attention is the fact that you have hyperfluorescent spots very early on. One right here, and maybe one or two spots right there. If you go later in the angiogram, these spots here are now leaking and becoming fuzzy, while this spot is not becoming fuzzy, it is just increasing in intensity. Therefore, we have two different characters of leakage here. This leakage, this is called pooling in a circumscribed space. This is most likely a pigment epithelial detachment, while this is leakage that is going to give you a pool of hyperfluorescence around this area. This is a neurosensitive retinal detachment with due to CSCR, in which there is a pigment epithelial detachment and a neurosensitive retinal detachment. Here's a fluorescein angiogram in the early phases of the laminar venous flow. And what attracts the attention is the presence of abnormal pinpoint hyperfluorescences in the center of the macula, as well as other hyperfluorescences throughout the macula, which we're going to follow. Remember I told you that the foveolar vascular zone has to stay dark. So as soon as you see any type of hyperfluorescence in the fovea, this is strictly abnormal. If we go further, this is in the recirculation phase. We notice that these hyperfluorescences are increasing in intensity. And if we go in further, we notice that some of them actually are very fuzzy. Therefore, we can easily say this is leakage. This is the fellow eye of that same patient, in which there are also hyperfluorescent spots that are fuzzy and lesser fuzzy hyperfluorescent spots nevertheless. And here we have RPE changes that are giving this track of window effect due to epithelial tract in neurosensitive retinal detachment. This is much later. Let me go back for one here. Here it is, that spot. Here it is, this spot here. This spot now is actually increasing in intensity and size, easily leakage. So are these. These are all pinpoint hyperfluorescent spots due to incompetent RPE that are going to give you pooling of the fluid in this area in a case of chronic central serous chorioretinopathy, in which there are many epithelial changes. Here's another example of epithelial changes due to chronic fluid that continues to go down through the effect of gravity and deplete the RPE from its pigment, giving window effects. Now, what attracts the attention in this angiogram, which is in the early phases, we are in the arterial phase, or perhaps the very, very earliest laminar venous phase. What attracts the attention is the fact that there is a hyperfluorescent spot at the fovea. Now, we know that we are in an early phase because we don't see any vessels or any fluorescein in the veins, but we also see patchy choroidal filling, so the choroid has not filled yet. However, in the background, we are seeing a hyperfluorescent spot, which we are going to follow. Now, this hyperfluorescent spot is increasing in intensity. It has a hypofluorescent rim. This phase is now in the laminar venous phase. You can see that the veins are starting to have that peculiar laminar flow, and the choroidal background is steadily increasing. We are still in the laminar venous phase with more filling of the veins, and this lesion is definitely becoming more intensely hyperfluorescent and more fuzzy. Now we can easily say there's leakage because there's an increase in the size and in the intensity. Which phase is this? This is in the recirculation phase, mid-recirculation phase, in which the veins are more bright than the arteries, and which the background is starting to lose its fluorescence, and you can see the large choroidal vessels darkly silhouetting against the bright background. The area in question is definitely becoming brighter, and the rim of hypofluorescence that we saw earlier is not as clear as it used to be before. Much later, in the very late recirculation phase, the background is very dim. The large choroidal vessels are dark and silhouetting against the brighter background, and you don't even see the rim of hypofluorescence anymore because the leakage has masked it. And in this context, what this is basically a classic choroidal neovascular membrane in a patient with age-related macular degeneration. This is how it is: early hyperfluorescence and late leakage. Here's another case in which we are in the laminar venous phase, so a relatively early transit phase. And what attracts the attention is the presence of a patch of hyperfluorescence right here, and multiple pinpoint hyperfluorescences throughout the macula. If we go further, this is in the venous phase where the veins are equally bright as the arteries. This area here is more hyperfluorescent and is starting to become fuzzy. The other areas are also becoming more hyperfluorescent. Now, in a much later phase, where the veins are brighter than the arteries, so we are in the recirculation phase, this area now is becoming very fuzzy, and a lot of these pinpoint hyperfluorescences are not becoming fuzzy, but maybe some of them are. So some of them are leaking, and some of them are, at this point, just picking up the fluorescein. What this is a bunch of drusen, again, in a patient with age-related macular degeneration, and what we saw there was a typical choroidal neovascular membrane that is a classic membrane with early hyperfluorescence and late leakage. Here's another example in which we are in the relatively early phases of recirculation, in which there is a hyperfluorescent lesion. I'm sorry, hyperfluorescent lesion just above the foveal center with a hypofluorescent rim. In the late phases, in the late recirculation, this lesion is intensely fluorescent and fuzzy, and those pinpoint hyperfluorescences, some of which are just picking up the fluorescein but not becoming fuzzy. These are drusen, these are not microaneurysms, and you can see definitely that there is leakage. And this is a choroidal neovascular membrane with a little bit of blood. Here is the subretinal blood, right there. You can see it right here, and it causes this blockage. See how the blockage remains stable in size, right there. Now, choroidal neovascular membrane doesn't always happen in AMD, and this is another case in which you can see there are unusual hyperfluorescent lines that appear in the mid phases of the angiogram around the optic nerve in a stellate manner, simulating vessels, and an unusual hyperfluorescent area in the nasal part of the macula. And if you follow that, this unusual part, in this area here, you have this area here has now a lot of leakage. It's intensely picking up fluorescein. The rest here is not as fluorescent as before. So we can easily say that this is an area of early hyperfluorescence that has increased in intensity and that has decreased with time. So this part of the lesion is a window effect due to RPE atrophy, but this part of the lesion is increasing in intensity, becoming fuzzy, so this is definitely leakage. And in this context where the lesion look like it's surrounding the optic nerve and radiating from the optic nerve, such as vessels, and accompanied by a lesion that looks like a classic choroidal neovascular membrane, the most likely diagnosis is angioid streaks. And we know that angioid streaks can get complicated with choroidal neovascular membrane. This is a patient with peripapillary chorioretinal atrophy. You can see the choroidal vessels shining very neatly in the early phases of the angiogram. You can also see linear lines that are unusually present. This is unusual, hyperfluorescent lines. Now, these hyperfluorescent lines remain as is, but there's one area here that starts to pick up the fluorescein, and if you go further, you will notice that this whole area is starting to leak and become very fuzzy. You know that you're in the late phases of the angiogram because the choroidal vessels are very, very dark against a dim background. And this is a choroidal neovascular membrane that has complicated degenerative myopia. This is a fluorescein angiogram with a wide angle viewing showing multiple hyperfluorescent spots. We know that we are in the early recirculation phase because the veins are brighter than the arteries, but they're relatively still quite bright, and there are multiple pinpoint hyperfluorescences of different sizes. When we go much later, in a late recirculation phase, only these ones are picking up the fluorescein, but they are not fuzzy. Therefore, we will call this area staining, while the rest is becoming dimmer, like the rest of the angiogram, and therefore this is a window effect. This is a case of autosomal dominant drusen. Here's a case of a myopic choroid degeneration in which the peripapillary chorioretinal atrophy is seen very clearly here. There are no choriocapillaries in this area, and therefore the background is dark because there are no choriocapillaries to leak. The choriocapillaries that are still healthy at the edge of this patch here, they are going to progressively stain the background and stain the sclera progressively if we wait long enough. Same thing happens here. This is a patch of chorioretinal atrophy right there in which there's hardly any choriocapillaries, and therefore it is very dark compared to the rest of the background. It has bright choroidal vessels, and slowly as we go along throughout the fundus angiogram in the late phases, the healthy choriocapillaries around here are going to stain the background. This is why in the late phases the background is not as dark as in the beginning. Which phase of the angiogram is this? Can somebody tell me? Can you hear me? Does anybody know which phase of the angiogram is this? Somebody said autofluorescence. Well, actually, you're close. This is not an angiogram, and the reason we know this is not an angiogram is because there is no fluorescein in the veins. But this is a red-free picture. Okay, and in autofluorescence, you would not have a very bright optic nerve head. So yes, this is a red-free picture because the optic nerve is white, okay, and the vessels are dark, and anything that is going to be red is going to appear as black. Okay, so anything that's red is going to appear as gray or very dark. Very good. All right. So this is another case of severe chorioretinal atrophy around the fovea and within the fovea that is due to progression and enlargement of grid scars that were performed many, many years ago. What happened here is you have chorioretinal atrophy, and each area of atrophy is very dark, has some vessels passing through it, choroidal vessels passing through it, and surrounded by a rim of hyperfluorescence from the healthy choriocapillaries. With time, as we said, that same mechanism, the healthy choriocapillaries are going to stain the sclera in the background and are going to give you the staining. This is of the background here. This is why in the late phases, the area of choriocapillaries as choriocapillary atrophy, chorioretinal atrophy will appear less dark than in the very early phases. Unfortunately, this patient developed a complication, developed a choroidal neovascular membrane from the scar, at the edge of the scar, which is right there. We cannot see it very clearly here. We have no idea. Basically, all what we see is this jumbled up hypofluorescence. But as we go throughout the angiogram, we start noticing that there's a network, a hyperfluorescent network that looks different from the rest of the scar here. And if you wait long enough, this network is hyperfluorescent and is leaking very brightly. This is actually a choroidal neovascular membrane right there. And the blood from the choroidal neovascular membrane is blocking the fluorescein right there. And if you notice, this blockage does not change. Here it is the same. Now let's look at some retinal vascular disease. Here's a fluorescein angiogram at 19 seconds. What attracts the attention is that there is fluorescence in the background, but what attracts the attention also is that the retinal arteries have not filled yet. Now, it may be too early to say. Maybe the injection of the fluorescein wasn't, strong enough, or the timer is wrong. So we're going to give ourselves another second to see whether the retinal arteries fill completely or not. But we know for sure that the choroidal circulation is okay because there is patchy choroidal filling. Many seconds later, the arterial circulation is still not filled. We know for sure that we have an inflow problem in the retinal circulation, that there is a delay in the retinal circulation, and this is enough for us to say that this is a central retinal artery occlusion. What we notice is the choroidal background is also bright, but what we notice also is that the center part, right there, this area is a little bit hypofluorescent compared to here, and we do not see the background details in this area right there compared to here. The background details, the vessels of the choroid, we can practically see them. In this area is very smudged, signaling that there is some blockage. Now, this is what we call a ground glass hypofluorescence. Here it is, as many seconds later, the retinal arterial circulation is still struggling and is still not filling, and we have what we call the leading edge of dye. We can see how the dye is into the arteries and is unable to progress any further. This is the leading edge of dye with the ground glass appearance. Much later, notice how the arteries are very attenuated and the choroidal circulation is starting to decrease. Despite that, the retinal circulation is still not filled. For sure, this is a retinal arterial occlusion with a ground glass appearance in the center, signaling that this is a relatively recent retinal arterial occlusion of the central retinal artery, and what we have is most likely a large cotton spot, an ischemic retinal whitening, which is right there. Here's the ischemic retinal whitening that is causing this ground glass appearance, and here is that shaded gray spot signaling the presence of an acute recent central retinal artery occlusion. Here's another case in which the background fluorescence seems to be relatively okay, but in which the retinal circulation seems to also be abnormal. You can immediately notice that there is an unusual sparsity of vasculature in some areas, that there are hypofluorescent spots in the center, and there is also a hypofluorescent area in the center, not as dark. This could be blockage, and this could be hyperperfusion or blockage. We're going to see that. We're going to notice that these arteries are terminating in almost like a dead tree branch, dead branches of a tree, right there, with the leading edge of dye in almost every artery. The veins themselves are not filled at this point. We know that these are veins because veins cross arteries, and we said that veins do not cross veins and arteries do not cross arteries. So therefore, the vessel here that is crossing this is definitely a vein. If we go a few seconds later, we notice that the pattern is basically the same, but now we are starting to see some venous filling in this area. We almost can see the red blood cells sludging into this vein, signaling a very slow circulation. In the periphery, there is a leading edge of dye and lots of spots of hypofluorescence throughout the fundus, signaling the blockage. Here is again, there is staining of the wall of the vein. Obviously, they're in an ischemic area, and the leading edge of dye in the arteries. And much later, in a very late phase, you can see that the areas that were blocking, the blockage is the same. This area remains very smudged, like a ground glass appearance, and the veins are very staining. It's not normal to have veins inside so late in the angiogram. Here again, and what this is a central retinal artery occlusion with a combined venous occlusion, as we can see by the presence of the hemorrhages. These were the areas that these hemorrhages, intraretinal hemorrhages, were the areas of blockage, and the ground glass appearance was caused by this ischemic retinal whitening. Let's look at this angiogram now. We are in a laminar venous phase. We can see some venous filling coming in here, but very early on and early here. The background seems to be okay with patch choroidal filling, which is normal at this stage. And in this area, you can already see capillary filling and venous return. You can see that the veins are starting to fill. If we go a little further, we notice that the retinal arteries is filled nicely and normally all the way here and here and here, and the retinal veins, the venous flow is coming back nicely, except in this area. When you follow this artery seems not to be filling. This is abnormal. In addition, you're seeing an area of hypofluorescence right here with the ground glass appearance. If you go a little further, the venous return is nice everywhere, but here there's this area of hypofluorescence, and the artery right there is still not filled. We go a little further, and then again, this artery does not seem to be filled, and it is smudged in this area while the background choroidal fluorescence is very distinct, and we can see the background detail very nicely, but in this area, you cannot see. Now, this is the artery and this is the vein, and this is the artery. This branch of the artery is filling nicely. This branch of the artery is not filling. However, this branch of the artery does have some segmental filling. How can this be? How can you have segmental arterial filling if the blood is not going in this direction? Where did this filling come from? Well, this is what we call retrograde filling. What happens is that in this area, you have basically the artery is filling. Sorry, let me get this out. The artery is filling this area, and it's not filling this area, and therefore this area here becomes very low perfusion. And what happens is, as the veins bring back the blood from the periphery, the veins that are stained are going to be of a higher perfusion level than the artery. And therefore they're going to push the blood in the veins is going to go back through the capillaries and go in an inverted circulation from the veins through the capillaries into the arteries and give you the segmental retrograde filling. This because in this area the arterial perfusion pressure is so low that the venous pressure is higher, and the blood from the veins is going to go back through the capillaries and backwards through the arteries. This area here is ground glass appearances, which already tells you that probably you have a cotton and this is hyperfluorescence. What you also notice abnormally is that this eye has some abnormal hyperfluorescence just under the fovea. This is in the later phase. You can see that this segmental filling is increasing, the background segmental filling. This is a typical retinal branch arterial occlusion in a young woman, and this is the cotton spot that gave this hypofluorescence and the spot appearance. And this lady had some window effects. She had RPE changes on the fovea, even the RPE changes on the fovea, the hypofluorescence. So here's another case in which there is an abnormal sectoral area of hypofluorescence in the superior part of the eye. If we go a little further, we'll notice that this abnormal area has many lesions. It has pinpoint hyperfluorescences, as we're going to follow. It has an area of a vessel here that is bright and cross over. And it has also these dark areas with a hypofluorescent rim. If we go further, we'll find that this vessel that I'm talking about is actually staining, and the staining stops right there, right at the level of an arterial process. Right there. There is actually a vein that is supposed to be going from here to here, and this vein is blocked by the arterial process. Right there. The vein is supposed to go from here and all the way to the so the vein is supposed to bring the blood all the way back to here, but this part of the vein is blocked by the arterial process. So this is a macular branch vein occlusion with telomere capillaries that are leaking the fluorescein, and this patient was treated in another institution with some grid lasers, and every laser scar is a chorioretinal atrophy that is dark in the center early on, with a hypofluorescence membrane because of healthy capillaries along, and in late phases, the healthy capillaries are going to stain the sclera and give you these hypofluorescences. And then the vein is staining because the vein is here it is. You can also recognize the blood that is causing the blockage in this area. All this blood is causing a blockage. Hypofluorescence is due to blockage. Here's a case in which immediately you recognize that there is an unusual delay in the venous circulation in the superior part of the retina, right there, compared to the inferior part of the retina. You have laminar venous phase here, but the veins are still not filled like that. And if you wait a little bit more, you'll find that the veins now are starting to stain, and that there is some blockage and staining of the retinal tissues around the veins. Much later, you'll notice that the veins are staining, the retinal tissues is right next to them, leaking, because they are sick from the vascular occlusion. This is a typical case of retinal vein occlusion. It is non-ischemic. As you can see, there are no major areas of capillary non-perfusion. So this is, I apologize. So this is actually a case of non-ischemic vein occlusion. Here's a fluorescein angiogram. In the early phases, you have arterial filling in this area and no venous filling yet. The background filling seems to be okay. It is still patchy, and you can see the large choroidal vessels very lightly silhouetted against the jaw cord. As you go further, you notice that there are some abnormalities in the vessels. Let's go one more time. One further, we start to notice that in the lamellar phase, we're starting to see the retinal vasculature much more clear, and we're starting to see telangiectatic vessels. These telangiectatic vessels, here they are, and we start to see a little bit of hyperfluorescence around this area. It seems fuzzy. Let's watch these telangiectatic vessels. They are increasing now in intensity. You can see very clearly, and you see these unusual anastomoses, this collateral vascular. Here you see this vein of the vessels that bridge changing the veins in the interior part of the retina are normal. The whole vasculature in the superior part of the retina is abnormal with all these telangiectatic vessels. And what's happening here is that these venous collaterals, because the veins here are blocked, these venous collaterals are, the blood here is unable to go back to the optic nerve normally. What's happening here is that the blood from the superior part of the retina is going through these small collateral channels back into the veins of the inferior retina and going back to its destination. You will see the collaterals also at the edge between the normal and the abnormal. So the area of abnormality is sectoral. It is confined between this superior line and the line at the line at the horizontal retina. Abnormal vasculature of the retina in the superior part of the retina, while the inferior part of the retina is normal. Combination of both telangiectatic vessels that are leaking, but also collateral vessels that just show up and they don't seem to be leaking. Notice here that the collateral vessels are not leaking. You'll see them. Here again, these are the telangiectatic vessels from the abnormal circulation, and here are the collateral vessels that do not leak. But they just help reduce circulation to establish itself. This is a typical case of vein occlusion. Superior retinal occlusion that is old because of the presence of collaterals, and the occlusion happened right there at the crossing between the artery and the vein. Much later on, the telangiectatic vessels can give you retinal edema when individual arteries are tissue. So again, this is what it looks like. An old branch of occlusion with collateral vessels right there. Here is a composite collateral vessels at the edges between normal and abnormal retina, and telangiectatic vessels. Notice that you have hard exudates, but the hard exudates on the opposite, they translate, they do not leak. So contrary to concomitant pulse leakage, hard exudates will not translate fluorescein angiogram directly transparent unless there are exudates. In that case, they will block. Here's a case of another retinal vascular disease in which immediately you notice that there's an unusual hyperfluorescence right there, and an unusual vascular loop right there. It's still not fluorescein, and there's also an abnormal hyperfluorescence at the focal edge, and an abnormal telangiectatic vessels there. This is not enough fluorescein. That's what happens later. A few seconds later, we are still in an abnormal flow, and we see that there are lots of both collateral vessels, but also normal vessels, and long fusion. No vessels in this specific in between the large vessels. Going further, you notice this area which has hyperfluorescence is not looking up the fluorescence, and you notice that it is filling at the same time as the vein. Let's go back. Here, first time, the artery was can see that it's narrow artery. It's not a normal artery, but this area is high fluorescent, while the vein is not fluorescent. Now, if you go further, you will notice that when the vein has filled, this area has filled as well. The other area, which we saw earlier, which was this loop back, this area was also hypofluorescent at the same time as the vein. Now let's further. It is starting to fluoresce at the same time as the vein, and now it is also making fluorescence at the same time as the vein. This is the vein. It is still less hypofluorescent than the artery. Are still in a little phase. If you go further, now the veins are more hypofluorescent than the arteries. We are in sensation phase. The area that is hypofluorescent is starting to become fluorescent. With the venous flow, it's becoming very hypofluorescent. And it's starting because while this area is maintaining its shape, it is hypofluorescent, but it's very clean. In between, you will see an abnormal vascular structure and normal vessels in between these changes in the artery. You also see a zigzag of little collateral corpus vessels back there. And also here, signaling this physical collapses. If you go much deeper, that area now is leaking. They can easily leak into the traces, masking the fluorescence background, signaling that this is vascular structure originating from the vein, leaking into the traces. Therefore, this is basically a normal vessel. While this one has decreased intensity, it decreases the vascular circulation and the vascular circulation, signaling this is a collateral vessels. Again, all the veins in this area of this skin are going to have fluorescein. The walls are fluorescein. So this is an ischemic vein junction with neovascular vessel, and collateral vessels like leaking and this with the collateral vessels here. Bringing the circulation from here to here because the obstruction of the vein is there. So this collateral is shunting the circulation from this area directly to this vein here. This is I'm going to go back here. This is basically a case in which at various seconds you will see that the circulation of the vein is slow. This is 35 seconds. Usually the vein should fill in 12 to 15 seconds. But in this case, the veins are taking very long time. The artery seems to be like 50 seconds. It's complete, but the veins are taking very long time. 35 seconds. You're still in the phase. You go further, and this is 5 minutes. The veins are staying in, and there's a small staining, and there's leakage from the walls into the cavities. And something into the tissues. This is non-ischemic vein junction. This is another case in which what strikes you is abnormal hypofluorescence throughout from this background. Now you may want to say, this could be bacterial fluid, so I'll grant you that. Let's say that this is bacterial fluid, and as we go further, we find that this cannot be bacterial fluid because there's an unusual dark hypofluorescence from this that does not correspond to abnormal globules, and that seems to be retinal. If you're not convinced, don't go further. The background is my side, but in between the retinal vessels are areas of hypofluorescence, and there's much area. There's much area. Signaling this would be causal response to capillary future. But this is ischemic gut vessel with a lot of causal response. Here it is. Initially, this patient has vasculitis. This was worked up. Well, this was actually a lot of causal response because of ischemia. Patient has obstruction with the ability of filling the veins. Basically, diagnosis is ischemic. Now, this should recognize this is a fluorescein and the States earlier on. strike cells like there are in many cancers of hyperfluorescence. The background of fluorescein angiography seems to be okay. There are some patchy filling in middle, which will follow that. But there's some unusual structure that is hyperfluorescent on top of the optic nerve. We'll follow that, and then we'll see immediately that this unusual structure is starting to be very hyperfluorescent and fuzzy, as well as some other areas. There are areas in between vessels, that's vessels that are hyperfluorescent, okay, and smudged. And there are multiple tiny pinpoint hyperfluorescences throughout the fundus, and then those stable areas like hyperfluorescence, as I said earlier, probably associated with blood. As we go later, we see that those areas are now profusely leaking very intensely, and now seeing very clearly the demarcations of the areas of capillary cleansing and capillary protrusion. Here, and of course, this whole patch of capillary protrusion with the association of pinpoint hyperfluorescent dots that will follow, and we see that actually those hyperfluorescent dots leak these microaneurysms in the case of diabetic retinopathy, which is influenced by diabetic retinopathy, as you can see from the presence of the nerve vessels of the optic and the nerve vessels elsewhere. This tremendous amount of ischemia throughout the joint. Here again, a lot of ischemia in the periphery, ischemia that I said earlier here. This staining, every time that you have retinal ischemia, the vessels that pass through the area of ischemia stain. So you can see that there's a staining on the walls of the veins. Okay, this is almost like a laminar beam flow, but you know that this is a late staining because you have leakage. You don't see leakage in the other things, and because the background processes are distant, and that's also the veins and the arteries are dead. But what's happening here is you have staining of the veins because of the amount of ischemia that exists. Although the microaneurysms are leaking into the retina, giving this hyperfluorescence, okay, like edema, there is an unusual irregular foveal ascleral because it's focused ischemia. There's capillary non-perfusion throughout the macula and periphery and disease and NVD. This is a proliferative diabetic retinopathy, and all those areas that was earlier of hyperfluorescence correspond to the leakage by the hemoglobin by the blood. There's the fellow eye of Sawsam showing the nerve vessels of the disc and elsewhere, and also showing the hypofluorescence due to the pre-retinal hemorrhage. Here's another case in which there's an unusual vascular loop there, and on top of the optic nerve. This is an early phase angiogram with some with the blood vessels being still right, the larger blood vessels are right, so we know this is an early phase of the angiogram. The retinal arteries are still not completely filled. We're going to give it 1 more second to see if it fills, and 1 second or not. Actually, we hope 1 second or more, we can see that there are still there's a leakage in angiogram, there's an initial problem, there's a very low perfusion pressure in the eye, and practically no circulation, no retinal capillary filling at all. There's only capillary filling here, and of course the veins are not completing and not blood filled with fluorescein because there is no sense in this area. This area here of this abnormal vascular is profusely staining and profusely leaking fluorescein throughout the angiogram, and only circulation of the retina is reduced to this tiny geographic area of macula, which the fovea is disrupted and barred, and there's tremendous amount of perfusion throughout the retina, and leakage, massive leakage, which blocks the visibility of the rest of the fundus. This is again proliferative diabetic retinopathy, a very bad case of proliferative diabetic retinopathy. Here's the fellow eye with the presence of pre-retinal hemorrhage, and you can see the pre-retinal hemorrhage masking the outlines of the retina and even the optic nerve. Here's a wide-angle view of a proliferative diabetic retinopathy with the presence of massive capillary non-perfusion right there, and the presence of normal, tight networks of vessels around the periphery. And these networks vessels are profusely leaking. These are lots of NDEs, lots of capillary non-perfusion in the periphery, and again, Okay, this patient may have even 20/20 vision because the center looks reasonably vulnerable, but the periphery is massively ischemic with lots of emphasis. This is again peripheral diabetic. Which phase is this? I need somebody to answer me. Can you hear me? Does anybody know which phase this is? Okay, I don't know if you're still there, but this is actually also the regulatory picture in which the optic nerve is right, and the vessels are dark because there's no fluorescein in them. Here's a case of another proliferative diabetic retinopathy with massive vascular structure in front of the retina and massive leakage from the NEs into the vitreous. Massive capillary perfusion. Again, proliferative diabetic retinopathy with NEs. Now, this is a case in which there are in the early recent condition phase, with the veins being much brighter than the arteries, and you can see that there are hyperfluorescence on the fovea leaking, and the leakage is basically pulled into the outer spexiform layer spaces. This is the case of leakage from these point areas. These are obviously not losing because they are leaking. This is a classic case of macular edema due to diabetic retinopathy. And again, notice that these hard to exudates do not translate. I'll show you it again. The hard to exudates, we do not see them on a fluorescein angiogram. Here is another case of an early fluorescein angiogram in the laminar venous place, in which we see an abnormal network of vessels at the macula, as well as pinpoint hyperfluorescences throughout the macula. All of them look actually profusely, and if you pull in the cystoid spaces right there, giving you what clinically would look like a cystoid macular edema. Leakage throughout the fundus in a case of diabetic retinopathy. Again, I've showed you this before. This is an area. This is a patient who has retinal telangiectasia right next to the fovea, and the temporal part of the fovea, and the retinal telangiectasia. The vessels are going to again leak throughout the fundus. Next here, and also staying here. This is a case of Martel, just the fourth telangiectasia. And this is another case in which you have an abnormal vascular structure along an artery. We note that this is an artery and this is a vein because this is this one has laminar flow and this one doesn't have laminar flow. This one is the artery, this is the vein, and it is along the artery. This is an arterial macroaneurysm in a patient who was hypertensive, which bled, and the bleeding occurred in front of the retina. And here, these are pre-retinal hypofluorescences, blockage of the retinal vasculature due to bleeding under the retina, causing the hypofluorescence right next to it. This is a case of macroaneurysm. Retinal inflammations, we've mentioned this before. They usually give you hypofluorescence bleeding and late staining, and when you have vasculitis, they also give you staining of the vessels. Now in hereditary conditions, we're going to go through this very quickly. Can anybody tell me which phase is this? Yes, Dr. Barbet is correct. This is an autofluorescence. We know this because the optic nerve is very dark and there's no fluorescein in the retinal vasculature itself. This is not a fluorescein angiogram, so it's not a trick question. But you guys are not tricked, so I'm very happy that the message got across. Here you have a hypoautofluorescence, signaling the absence of RPE or RPE, a loss of RPE function or a loss of photoreceptors. This is a patient who has actually Stargardt disease. And on a fluorescein angiogram, now we know that this is a fluorescein angiogram, you notice that the arteries are being filled. We're going to watch that. You notice that the choroidal vessels, we can see them very, very clearly. But you also notice, and actually even here, you also notice that this choroid is abnormally dark. You're not seeing the patchy choroidal filling as much as you might like to. And here, when you go much later, KX5, minutes, you still not see the choroid as much as possible. So this is what we call choroidal silence. Now, choroidal silence is very characteristic of Stargardt disease because the RPE is packed with fluorophores, but choroidal silence can also happen naturally in patients who is doubly pigmented. So black people also have choroidal silence because the RPE is very heavily pigmented, and therefore we don't see the choroidal background very clearly. What you see in the center is, let me go back here, what you see is a hyperfluorescence, and this hyperfluorescence is stable in size, and I did not show you the transit, but this hyperfluorescence has increased and then decreased, therefore it is what we call a window effect caused by RPE atrophy. That is a case of Stargardt disease. Here, again, I apologize. Here is a case of Stargardt disease in which you can see the flex, the RPE atrophy at the center. This RPE atrophy translates as a window effect in which there is early hyperfluorescence, increasing hyperfluorescence, but then decreasing hyperfluorescence compared to here. See that the background also is hypofluorescent with some hyperfluorescent spots. These hyperfluorescent spots, each one of them increases in intensity and then decreases, signaling that these are window effects. The full background is quite dark, but in the areas where you have RPE atrophy, pinpoint RPE atrophy, that is going to manifest by pinpoint hyperfluorescences that decrease with time, signaling that this is a window effect. Okay, notice that in Stargardt you also have normal preservation, a very dark colored pattern, a black background here around at the optic nerve. This is actually quite characteristic. This is a case of vitelliform macular dystrophy in which you have a blob of subretinal fluid filled with fluorophores. And on the autofluorescence, this is very hyperautofluorescence. Hyperfluorescent, when you do a fluorescein angiogram, this is early in the laminar venous phase, and this is late. As you know, it's late because the background is dark and the vessels are darker. And here, what you can see here that this is blockish. So hyperfluorescent lesions due to Best disease are autofluorescent. And when you do a fluorescein angiogram, the dye in the background is so bright that, relatively speaking, this area, which is normally autofluorescent, appears darker than the rest. This intensity is exactly the same as this intensity. However, the background here is very dark, and therefore it appears bright, but here, because the background is so bright, this appears dark. And this is a blockage of fluorescein from this area. Now what happens is, because this is actually a subretinal fluid, what happens is that the fluid that goes under the retina is going to stay in the background, and this is why in some cases we don't have so much liposuction like in this area here. We don't have we have the clearer fluid is in this area up here. The clearer fluid is going to let the background fluorescence go through, and you don't have as much blockage here. Therefore, you can see it. But here, this is. I hope this is clear. I'm going to very quickly through.
Okay, are you still there? Is everybody still there listening? Hello?
Yes, Doctora, we're still here.
Okay, there's about 5 more minutes on tumors, but I don't think that is as important to you as the basics and the vascular and the degenerative diseases. So I'm happy to entertain questions, but I think you have another lecture, right? Do you have another lecture in 10 minutes or 15 minutes?
The next lecture is at 11:30.
Okay, would you like to see the part of the tumors, or shall we just take questions? Because it probably is a heavy dose, but I'm happy to show you the rest of the video, which is about we have like 6 minutes more of video, and or if you prefer, we can just take questions there to to elucidate some areas that you didn't understand, which is also equally good. Is everybody there, or did you guys leave?
We can hear you, Dr. Yes.
Okay, so I'm waiting for your questions. So whoever has a burning question, and there's no shame in asking questions, and there's no shame in not understanding, because you guys may not know this before, so this is new to you, and I understand that it may be a little bit too much. So why don't we go over what you didn't understand? What parts did you want to clarify?
Sarah?
Yes.
السلام عليكم.
وعليكم السلام.
دكتور كيف نفرق ما بين الدروزن والمايكرو انيوريزم؟
Microaneurysms leak. Microaneurysms are vascular changes in the retina. They get filled with blood and then they leak. So in the beginning, they will appear as hyperfluorescent spots compared to the background. And if you wait after 1 to 2 minutes, you'll start to see that they become fuzzy. Drusen are basically fluorophores accumulating behind the RPE, as I showed you yesterday. So they're going to, appear as hyperfluorescent, but they will not leak.
Doctor?
Yes.
Also drusen autofluorescence or
it depends
in the beginning?
Okay, that's a good question. It depends on the size. If you have a very large drusen, that is a soft drusen, that is the fluorophores are a lot, it's very dense, and there are basal linear drusen, so in the basement membrane of the RPE, you may have some autofluorescence, but it's going to be very difficult to detect autofluorescence on a regular fluorescein angiogram, but you will be able to detect it if you do a specific autofluorescent test. You will be able to see those pinpoint hyper autofluorescent spots. But on a fluorescein angiogram, usually the filters are not they're not made to detect autofluorescence in particular. So you need lesions that are relatively large in size, such as a vitelliform lesion or an optic nerve head drusen, which tend to be a little bit bigger. Those you'll see them easy on a fluorescein angiogram in the control shot. But in general, drusen are represented as early hyperfluorescent spots, okay? And those drusen are going to, most of the time, decrease their fluorescence as you go, meaning they behave like window effects. And why is that? Is because oftentimes on the top of the drusen, the RPE is pretty thick, so it has lost its melanin and has lost its curtain function. So it's going to look like a window effect. Now, if the druse is very big, okay, and you have a lot of junk under the basement membrane of the Brooks membrane, then you can have some staining towards the end. Okay, so some drusen will stain, the larger ones in particular, and the small ones generally behave like window effects, like pinpoint window effects. Microaneurysms and abnormal vasculature after a vascular insult in the retina will behave like tiny hyperfluorescent dots that leak. So you need to see, when you see hyperfluorescent spots in the beginning, you need to see a little bit later on. Nobody interprets an angiogram just on the early phases. You need to see the full transit, and then you have to start seeing, how these lesions, every area behaves to determine whether you're dealing with a window effect or with leakage or with blockage. And based on that, you can, make a diagnosis. What else do you have? What questions do you have? Okay, you guys, I don't know, nobody's asking questions. I see 52 participants, but I'm not sure if you guys are actually listening or just like putting the video on and that's it and leaving. So are you all there?
Doctor, can you please re-explain the autofluorescence?
Autofluorescence? Autofluorescence is a natural phenomenon in the retina, okay? The retinal pigment epithelium has the capacity of phagocytosing the material in the discs of the photoreceptors. And the material in the discs of the photoreceptors is called A2E, okay? I mean, they're fluorophores, okay? And what happens is that the RPE itself is going to phagocytose the discs material and is going to bring back to the photoreceptors, recycle the material so that the photoreceptors can use it again. And as long as the RPE is healthy, you're going to have a steady level of autofluorescence, of ability to shine. Let's put it this way: the RPE is going to have a steady ability to shine through, in the retina that we can capture by photography. Now, if the RPE is overwhelmed, if the RPE is too tired, it's not going to be able to take care and clear all the material that is coming from the photoreceptors, okay? So it's going to start to accumulate those fluorophores inside the RPE, and therefore when you shine specific light at the RPE, it's going to shine back at you with higher light because it has too much fluorophores inside it. When the RPE becomes very tired, it's not just going to accumulate the fluorophores inside the cell, it's going to also push it back towards the Bruch's membrane, creating drusen. And those drusen, if they're big enough, they're going to also shine. If you have the photoreceptors are not interdigitating in the RPE, if you have the separation, if you have a neurosensory retinal detachment, such as like CSTR, for instance, or Best disease. In Best disease, the RPE is not in contact with the photoreceptor. The photoreceptors are off. Okay, and therefore the discs that are being shed from the photoreceptors are unable to be taken by the RPE, and the fluid in between starts to accumulate the material which is called lipofuscin, which is called A2E.